大家啦嚇，咁咧就
Well, it's time to start our meeting. Please refer to the agenda. Today we have 3 agenda items. The meeting would end at 7 p.m. and well, it can be extended if necessary. There were 3 information paper issues to members since the last meeting, and I've just received a letter from Dr. KWOK Ka-ki to propose a joint panel meeting. A meeting to be jointly held with the Welfare Services panel on youth psychiatric services. Dr. KWOK Ka-ki, if we disregard the recent case, the incident yesterday, well, the government should still have come back to brief us. There was a study carried out under the chairmanship of the former Secretary for Justice, Mr. Wong Yan-nong, and I think our young people are suffering now, so we need to do something about this. Well, you are proposing a joint panel meeting. They will come back to give an account sometime later. But now you are proposing something different, a joint panel meeting. So I would like to ask members if they think we should do this. We should have the joint panel meeting. Dr. Elizabeth Kwok, youth psychiatric issues are serious problems. In view of the recent case, I am in favor of convening a joint panel meeting. What other members think? Mr. Tommy Cheung. Chairman, if you ask me, I would say education is also important. We are talking about very young kids, age 2, 3, attending nursery classes and kindergarten and moving all the way up. Nursery come under the Food and Health Bureau, the Social Welfare Department, but kindergartens come under the Education Bureau. And if we want to convene a joint panel, let's also involve the Education Bureau. We have the funding, but we don't have sufficient manpower to serve kindergartens, to go to the kindergartens, to help the vulnerable kindergarten children by offering professional help. First of all, the teachers and principals should be able to identify suitable professional support for the identified children. So it's not a question of whether we have the money or not. Whether we have the money or not, there may still be problems with young children. Dr. KWOK Ka-ki, well, I agree with Mr. Tommy Cheung. If we have a joint meeting involving 3 panels, we'll be able to allow members of these panels to participate in the discussion. We're talking about panels, not what Dr. KWOK says as subcommittees. We are not subcommittees. So the education, social welfare, and health services, we would like to have a joint panel meeting. We will decide on the format and the date later. CB2 1021 1718 bracket 01. the addition of psychiatric wards to the Kowloon Hospital. Kowloon Hospital is a gazetted psychiatric hospital, but the government would like to ask us if we should have a discussion first before they proceed to the Gazette. Well, I'm in favor of having some discussion here. I would like to suggest that they come to talk to us first. Let's try the April. If members think that there should be a discussion first. All right. Let's move on to the second item. Items for the next meeting to be held on the 24th of April. Two proposed items from the government. First, a review of the implementation of smoking ban at the bus interchanges at the 8 tunnel portal areas. And the second item, IT enhancement project of Department of Health. Two items. So I would talk to the government whether we can set the next agenda on the basis of three items, including the one on the psychiatric wards. Now we move on to the next item, and that is I'd like to welcome the Secretary and the relevant deputations in respect of the legislative proposal for introducing tax reduction under the Voluntary Health Insurance Scheme.
好，咁就局長或者首先請你簡介一下呢。
Over to the Secretary for an introduction, please. Chairman, members, I'd like to give you a briefing on the tax deduction proposal, a legislative proposal for the Voluntary Health Insurance Scheme. As announced in the 2018-19 budget, the government would introduce an amendment bill to allow tax deduction for premiums paid under the Voluntary Health Insurance Scheme, so as to encourage the public to purchase certified and VHIS compliant plans. Premiums paid for them by person for himself or his dependent will be allowed for tax deduction. The annual ceiling for tax deduction of premium pay is $8,000 per insured person. There's no cap on the number of dependents that are eligible for tax deduction. We're going to introduce a bill for the tax deductions. The taxpayer, as a policyholder, if he pays for himself or his dependents in any particular financial year, the premiums paid in respect of a certified plan will be tax deductible, but this is only applicable to a certified plan. The bill would set out the definition of dependents, which will cover the taxpayer's spouse and children, and his or her spouse, grandparents, parents, brothers, or sisters. This is for the purpose of improving the quality hospital insurance plans, and also to enhance transparency for the consumer, so that policyholders know how the coverage is to be extended to their case, so that in the long run the pressure on the public sector can be alleviated. We encourage people to take out the insurance cover at a young age, so that they can continue the protection in later life. And we also want to encourage the insurer to come up with better terms, more attractive terms, such as guarantee renewal, no lifetime benefit limit, the offer of a cooling off period, and covering unknown pre-existing conditions, etc. We have briefed members over this proposal in order to address is considered a positive step in addressing the public-private imbalance in the healthcare system. But they are also of the view that there's no high-risk pool, but well, it's considered an appropriate balance to launch the scheme first before we consider the high-risk pool at a later date. We're now working out the details on the tax deductions. We plan to submit a bill to this Council for scrutiny in the second quarter this year. On this issue, we have been maintaining close liaison with legislative members and stakeholders. I thank the Council members and other stakeholders for offering their comments to us. We'd like to make sure that this will be a scheme that will benefit the general public. All right, 3 minutes for each member, starting with Dr. P.I. Chen. I would like to have a question, talk about the high-risk pool. CP2 1915, 16 to 17, paragraph 48. It said $50 billion has been reserved, and $43 billion will be for the support of the high-risk pool up all the way to 2040. And in 2009 budget, the $50 billion earmark was also mentioned for the purpose of setting up the high-risk pool and for setting up certain funds. So, where has the $4.3 billion gone? And now you are going to spend $10 billion for the public-private collaboration. We don't know what has happened to the rest. And it's also said that $50 billion will be spent on hospital redevelopment. And now it turns out that we are going to just to spend $10 billion on the scheme, and the high-risk pool is nowhere to be seen. Thank you. In 2008-2009, we earmarked $50 billion. It was not only meant for voluntary health insurance. It's for the healthcare sector reform initiative, which will cover health insurance and extending private health care and strengthening the system.
So of the $50 billion, $10 billion has been set aside for the public-private collaboration scheme. About $4 billion has been lent to Chinese University for the building of a non-profit making teaching private hospital. And so this will improve the public-private healthcare balance. As for the rest of the resources, it will be used to strengthen the public healthcare system in its various aspects. This includes the hardware, the $200 billion set aside for building hospital, and now you said that the money will be put in. Now this is recurrent funding and one-off funding. Now, so I think we shouldn't mix up the two. Where is the $50 billion that has been put in reserves? And now, perhaps I wasn't clear. It wasn't to be put into recurrent funding. The $200 billion for hospital building, that's a one-off funding. Elizabeth Quat, Of course, we think that with voluntary health insurance scheme, more people will purchase private health insurance, and this will relieve the pressure on public healthcare system. Now, there are some attractive aspects. For instance, a guaranteed renewal, preconditions covered, etc. But for those who have already purchased healthcare insurance, they are concerned. Now, they started purchasing insurance early because it's cheaper when they start early. Now, they took a look at the government proposal. Their agents tell them that their schemes might not be wholly migratable to the new scheme. And so they are worried that they either have to cut their present scheme or to and then to buy only the new one. And the deduction is rather limited. It's not that attractive because it's expensive to purchase health insurance. Now, $8,000 a year, and you are only refunding $1,200, so it's not very attractive. So if you can expand the coverage to cover existing insurance cover, and if you can raise the tax deduction amount, that would be more attractive. Now, right now, actually, we have been talking with the insurance companies, and we know that many people have their own hospitalization schemes, and the insurance companies do have plans for those schemes to be migrated, and they will have transfer arrangements. For instance, the policies concerned now under the providers will provide for switching to the voluntary health insurance. Now, if the person doesn't want to join the voluntary scheme, and if there are other insurance products that are not part of VHIS, they will not benefit from the tax deductions. As for the $8,000 amount, we have considered many factors. We have engaged independent consultant companies to do the calculations, and we've taken on board people's views. And also, the additional benefit is that there's no limit to the number of dependents for whom you will enjoy the tax deductions. So this will cover the parents, grandparents, and the siblings. So there you get a large tax deduction in total. Alice Mack. Now, Ms. Kwat asked some of these questions that I'm interested in. Now, we hope that those who have the money will buy the voluntary health insurance cover so that there would be less pressure on the public healthcare system. Now, you have made many changes. There is no high-risk pool now provision. And there are many who suffer from chronic illnesses now because there is no compulsory coverage so they will not benefit that much. Now, some others will enjoy the tax deductions. So how much alleviation in pressure on the public healthcare system would there be? Now, without the high-risk pool arrangement, now, what in your assessment after all these years, how many people would you expect to join? And do you think you would achieve the objective of alleviating pressure on the public healthcare system? Now, thank you. Now, the VHIS is one part only of our overall healthcare policy. Of course, we've worked on this a long time, and we are introducing this again. There are tax deductions, so people focus on voluntary healthcare insurance. But this is not the sole answer to solve the healthcare problem. Now, as people age in our population, there are many chronic illnesses. Now, for some minor operations and health checks, many people might be able to afford these private VHIS. Now, as for chronic illnesses, we have other strategies. The present term of government will devote a lot of attention on primary health care, and this will also help to control chronic illnesses. Now, for procedures where there is a lot of pressure, we have set aside $10 billion for public-private healthcare collaboration so that more patients will patronize private doctors. What's your expected number of patrons? Now, in the first couple of years, we expect that there would be about 80,000 or about 40% of the existing persons who have private insurance will transfer to will take up this new system, and in time we expect that over 1 million people will join. UC Wing. Now, many people have purchased healthcare insurance on a savings mode. Now, if the insurance company is willing to incorporate the proposed template into their scheme, this will achieve the government's objective of attracting more people to private healthcare insurance, relieving pressure on public healthcare system, and so will you consider extending the tax deductions to those people? Now, you said that you expect that there would be 1 million people joining the scheme in the first 2 years. Now, do you have a breakdown by age? Now, is it that the young people will not be attracted, whereas those nearing retirement age would be attracted to join? Now, in our policy, in our document, we said that the VHIS is mainly a hospital insurance for hospitalization. Now, as for non-hospitalization schemes, such as savings arrangements or where cash would be compensated, now that's not part of the scheme. Now, we've talked to the insurance companies many times. They are confident that under VHIS they will design some flexi plans that would be on top of the standard VHIS. Now, the insurance companies can sell any kind of product, but if they don't fall under the scope of VHIS, those plans will not enjoy the tax deduction. $1 million, 1 million persons. Now, what does that include? Now, right now, over 1 million people have purchased insurance by themselves. I'm concerned that those elderly people, they have difficulty in purchasing private healthcare insurance. They will join, but not the young people, and the pressure would fall on the insurance companies, so they might find this hard to sustain. Now, in liaising with the insurance companies, now they accept this proposal in its present form. Of course, we will launch more publicity and education. We hope more young people will purchase the insurance cover, because the coverage is much wider than existing coverage. So we will launch publicity to attract young people. Now, why do we do so much work on HIS to expand the coverage and offer tax deductions? Now we want to attract people to health insurance cover for the especially for young people. KWOK Ka-ki. Now the government is giving money to attract more patronage for the insurance companies and so on. Now, for specialist outpatient clinics, that may work, but for the hospitalization services, now those in the 20s to 40s, young people rarely need to be hospitalized. Now, well, for our young people, they have to repay their education loans. They find it difficult to pay rent. Now they have to spend over $10,000 to buy insurance cover. Now actually they won't receive that much benefit when they're 65. So you provide cancer treatment to the limit of limit of $80,000. Now breast cancer. Now these are around $200,000 to $300,000. Now the $80,000 is only one half of electrical treatment and 1/3 for chemotherapy. Now you should pay whatever is the shortfall. Now and they are 25 for 25 to 45 age group, you should pay 50% of the cover. Now you only pay them $80,000.
So it just mean that you are giving them a concession of $100 if they're earning just over $10,000 a month. And under this scheme, you do not regulate the premium and the profit of insurance companies. So you are actually making the policyholders victims. We're not trying to lure anyone into this scheme. The voluntary health insurance scheme aims at improving the quality of insurance products and to instill greater confidence in policyholders. And also for those who can afford it, there will be additional choices. It offers another option. This is not the answer to all the problems. We have other strategies to tackle the problems in the light of an aging population. There are other strategies that we would adopt to tackle these problems. What about helping those with coverage of $80,000, which is just 1/3 for chemotherapy treatment? If we want the coverage to be better, the premium will be higher. So you want them to pay more? The design of the VHIS is actually setting the basic standards, the minimum requirements. Of course, people can buy more flexible plans. We have done a market survey. We have looked into the general coverage in the market, so we don't make up these problems. Well, you are a healthcare professional. What's the $80,000 in terms of treatment costs for procedures to be carried out in the private healthcare sector? The prices are set by the private service providers. What we want to see is transparency in fees and charges, and that is the consumer or the policy holder would know all the information he needs in a transparent matter. As I've said, we want to make sure that people can have this additional option of taking out private healthcare insurance coverage if he can afford it. Mr. John Zhang earmarked $50 billion for this. We'd like to know what has happened to them, to the money. $10 billion has gone to the public-private collaboration, $4.3 billion to the Chinese university, and money has been spent on different parts. But you know that whatever mentioned in a budget may or may not happen. It doesn't mean that the FS has the sum of money in his drawer that he can spend at any time. I'd like the Secretary to give us a table. I believe in the special FC meetings, we would ask similar questions. What has happened to this earmarked sum of $50 billion now? How much was earmarked for the VHIS at that time? This paper talks about tax deductions. If the bill is passed by this council, are we in a way supporting a scheme without any high-risk pool? Is that you don't want to delay things, so let's phase in different features, and then we'll wait and see if later we can do something about the high-risk pool. But we are afraid that this will never happen. Can you tell us the factors and the supporting circumstances that would be needed to support the setting up of a high-risk pool? Do you have a timetable? You are going to submit a bill on this to the council in the second quarter. Do you need to do more in the law drafting? Other than the bill, do you need to do more for this to be implemented, apart from the code of practice in paragraph 15? I would like to ask members to pay attention to this paper. This is not a paper on voluntary health insurance scheme per se. It's about the proposed tax deduction under the VHIS. Members may have different views. I won't count this against you, Mr. Chen. The government once said that that there would be the need of another legislation, whether that would happen, we don't know. But now we are talking about the tax deduction under the voluntary health insurance scheme. If members think that we don't need to do this, then you may say that there's no need to amend the law. They are going to introduce a bill, and the Bills Committee will be set up, and you can move CSAs saying that the deduction amount is 80,000 instead of 8,000. You can do various things like that. But as I understand it, this is not a legislative proposal for the voluntary health insurance scheme. They're saying that if the insurance companies can do this and that, and you take out the insurance coverage, you can have a deduction, tax deduction of $8,000. All right. With this background in mind, members are free to speak your mind. And also, some background information on the $50 billion. Back then, it was proposed by the former Secretary for Healthcare Financing. So what has happened to that idea? Maybe the current Secretary should give us a table to give an account. I'll give you back the time that I have used to you, Mr. Ray Chan. Apart from what I've said, $4 billion to CU, $10 billion earmarked for public-private collaboration. The rest will be used to strengthen our healthcare system. As for the hospital development plan, which will cost us $200 billion, that would already take us beyond the $50 billion earmarked back then. We can give members of table as requested by Mr. Chan. And regard to the last question, I think the chairman has clarified the matter. We need to amend the Inland Revenue Ordinance. It's done through negative. Oh no, sorry, it's a legislative amendment exercise. There will be no other legislative amendments following that. And we'll have a dedicated work unit in the Bureau to look at the insurance plans and products, and the insurance authority will monitor the behavior of the insurance companies. That is after the legislative amendment and compliant insurance plans will be eligible for the tax deduction. Yes. How about high-risk pool? If everything goes smoothly in terms of the legislative amendment, we're going to launch this implement this proposal early next year, and then in the coming years, we would monitor the way that this is implemented. I mean, the voluntary health insurance scheme. We haven't given up on the idea of getting a high-risk pool. We would like to get some experience with the VHIS, and then I believe the experience would inform us on whether there should be a high-risk pool, and if so, how. I believe it would certainly facilitate future discussion. Oh, please don't misunderstand that Mr. Chan has spent more than 7 minutes because I interject in the middle. Mr. Wong Ting Wong. Well, I think they have think it over and over again to get this done, but the major missing part is the lack of the high-risk pool. People who are most affected, who are most vulnerable, will get some protection. But now what they need most is lacking in the scheme. If I am young and healthy, I actually don't need your help. Do you think that you can get 1 million people joining the scheme? If you have only a few takers, this will collapse. I'm a businessman. You may have expended a lot of effort into this, but it may be a better idea to wait until we have the high-risk pool instead of proceeding with it and meeting with failure. I want to make some suggestions which I think would make this scheme more feasible. If it's not voluntary, many people will be reluctant to join, because when you have the most cumbersome procedure to tackle when you want to make a claim. I don't know whether you have any experience. For example, in terms of vehicle insurance, whether you are the one who hit another car or your car's been hit, it will take you a year, more than a year, to get the compensation. If you can come up with a plan which can afford a better protection, I believe it will be very beneficial in promoting the voluntary health insurance. Second, tax deduction. I at first thought that you would save $8,000 in tax payment. Actually, it's just $1,200 or $100 a month. Well, that's too little. There's no reason why the benefit is so low. This is anything but a meager incentive. How can you encourage people to take this on? Or maybe we can give it more thought when we had the Bills Committee in the future. I thank Mr. Wong for his concern about the high-risk pool. The difficulty with this is there's no consensus. During the consultation exercise, there were voices raising strong objections that the government should fork out money, a large amount of money, to subsidize people taking out private health insurance.
We need time to reach consensus. Now, we will keep strengthening the public health care system so that it continues to be the mainstay of Hong Kong's healthcare system, and we will have a safety net. So this will always be available. Now, as for the $8,000, we have done the arithmetic. The Bureau and the Financial Services and Treasury Bureau, and we have taken on board the calculations by independent consultants. This upper limit will enable 90% of private healthcare insurance to be covered, to benefit in full. And also, the claimant can also claim the tax exemptions for dependents without upper limit. Now, just now, a member who is a doctor said that there is not enough supervision. Now, the government does need to supervise or to monitor the doctors and hospitals, and only then should you monitor the insurance companies. So I support the supervision of the fees charged by doctors and hospitals, but it's difficult to implement in the short term, and so you shouldn't talk about supervising the fees by the insurance companies. Now, if it's difficult to support the system if you just increase the fees by 10% odd. Now, you should make the fees more reasonable. For instance, appendicitis, you compensate by the same amount for all hospitals. Now, so the government should be bold in tackling the problem. Now, there are not that many poorly behaving doctors, but if you don't deal with it, even the good doctors will adopt the practice. So you should standardize the compensation amount. I think that's what the VHIS can do. Now, you have your system of supervision. You have insurance authority, and you have an organization to supervise these insurance organizations under VHIS. So that's duplication. So you can have two supervisory organizations in the short term, but better only one in the long term. Now, the $50 billion was supposed to be injected into the high-risk pool, and you should pay 30% of the cover when they are young, and you should pay more when they are 65. So let's have this injection of $50 billion. You can choose not to reply, Madam Secretary. I will answer. We thank Mr. Chen for his views. Now, all along, concerning the fees charged by private doctors, we are concerned. The insurance companies raised this issue before, so we've talked to the Association of Private Doctors. We want to increase the transparency of fees, and we have spent time on the relevant measures. They have to provide a table of estimated charges, and on their website they have to tell the patients about the figures on the fees charged. And although it's not a DRG, there should be more packages in the way fees are charged. So this will increase the stability in the fees. Now, the Food and Health Bureau has an office to supervise this. The insurance authority will have another, will also supervise, and they do different things. Now, the insurance authority will monitor the behavior of the insurance companies, and the industry feels this is appropriate. As for high-risk pool, at the time we could not reach a consensus, but we haven't given this up. If we convince most people in society that there is a need to set up high-risk pool, we would be ready to do that. Now, we need time to first introduce the VHIS, and then, based on the experience of implementation, we will study other measures that are beneficial for the public. Next, Fernando Cheung, for 3 minutes each, and then 3 other members. Now, we've talked about voluntary health insurance scheme for many years. I think it's been more than 20 years. Now, as for the latest consultation, as the document said, the findings were announced in 2017, and so you decide to set aside high-risk pool because there isn't any consensus. So you have now your latest version. Now, is this version the most suitable? Now, people have different views about whether it's worthwhile, and you're coming to the panel to proceed to legislation. Now, maybe you have skipped one step. Now, if we think this version is not appropriate, then let's not talk about tax deductions. That's the next step. So you should improve the VHIS plan, and only then should we consider tax deductions. So I think you have been taking the wrong steps in the wrong sequence. So maybe you try to respond in a hurry to current criticisms. Now, for some members of the public who purchase health care insurance, and if you offer them tax preferences, I think that's a positive step. But the current scheme doesn't really help the disadvantaged groups, the most needy. They are getting older. The premiums are getting higher. And you only increase the transparency, but it's still very expensive. So I don't support the voluntary healthcare scheme in its present version. Now, should we offer more options? I support that. So I'm against the present version. But in the future, there is a suitable version which helps everyone, I would support your legislation of tax deductions. The Secretary, we thank Dr. Cheung for his views. First, in January last year, we had done a consultation before that. Now, on the 12 items in the standard plan, we reached a consensus, and it was reported in the panel. Now, for the 12 minimum requirements, only 2 could not be achieved. The other 10 are very much in accordance with the wish of the public. So we want to introduce the 10 items first, and then deal with the other 2 items where consensus was not yet available. I understand Dr. Cheung's point that some items in the VHIS current version may not resolve all healthcare problems. This is not a plan to resolve every problem in our healthcare system, such as population aging and shortage of manpower. We have other measures to deal with those. So we still maintain that the public healthcare system is the biggest safety net for the Hong Kong public. For the disadvantaged groups, the safety net is always there. Well, for the disabled and for those in the low-income groups or who are elderly don't benefit from the scheme. They don't gain an increase in security. Cheng Hanpan. Of course, we understand that the government all along wishes to adopt the voluntary healthcare insurance or the previous mandatory healthcare insurance schemes so that there's a better balance between public and private healthcare systems. Now, in 2014, it was said that the proposal would result in a similar in a roughly equal balance. Now, what under the current scheme do you think will be the public-private balance? Now, maybe it's not a question of not enough hospital beds. It's a question of allocational efficiency. Now, 90% of the resources is placed under the hospital authority, but our efficiency has been falling. Now, for the $8,000 tax deduction currently proposed, how many people will be encouraged by that to purchase VHIS? I don't think it's very attractive because those who are really needy don't benefit. For those who for many others, they don't need to pay tax. Now, Mr. Wong Teng Kong said that he thought $8,000 was the tax benefit, but actually it's not. So it's not attractive. So you're asking us to amend legislation, and there will be a lot of work, but it may not be fruitful. Will you have better proposals so that the VHIS will really benefit the public and attract the public to purchase VHIS? Now, on your first question, by 2040, we expect that the public-private health care balance would be improved by 5%. As for the attractiveness, the tax deduction is the VHIS. The tax deduction is only one means to attract the people. We think that 10 items of minimum content is those are the real attraction. Now, many of these items are not currently available, so when people buy the proposed product, it will be of higher quality and people will be more confident in buying this product.
Can I get some information? It said that that would result in a 5% deduction. Can you give us the details? I can do it after the meeting. Mr. Siu Ka-chun. The VHIS is about how we deal with healthcare financing. We have to deal with healthcare financing because the population is aging. Now it's done on a self-finance basis. You take out insurance to protect yourself. In other words, for people who are concerned about policies, we are concerned that this may result in health inequality among the population. For middle-income people, they will be forced to the private market. Those who cannot afford it, those who have higher needs, they would go to the public sector. So they are stratified. They would be divided into different groups. So we are concerned about health inequality among our people. But there are other questions on policies that I would like to raise. Are there concrete policy objectives in terms of the success of the scheme? How many people have to be attracted to join the VHIS so that we can address the heavy pressure on the public sector? How many people would have to take the VHIS coverage before you can address the public-private imbalance? And also on tax deduction. The current proposal, how many people will be attracted to take out the insurance annually, and how much tax revenue will be foregone annually? I understand the issues you have identified. We need to rely on our public healthcare system to take care of everyone in Hong Kong. This is the safety net. And in the many rounds, during the many rounds of healthcare financing, people express strong opposition to involuntary or mandatory health insurance as a means to address the public-private sector imbalance. So we continue to invest in the healthcare system, but for those who can afford to take out insurance and who also want to get more choices, they will be encouraged to consider services in the private sector. As regards how many people would take out the VHIS insurance coverage, we believe in the first 2 years, 1 million people will either switch to VHIS or take out the insurance coverage. For the alleviation of pressure to the public sector, I don't think that we can see much accomplished in the initial stage. But for minor operations or simple treatments and procedures, the VHIS will be helpful, will be beneficial to the alleviation of the pressure on the public sector. We believe the tax revenue to be foregone under our projection will be $800 million. Mr. Junius Holt, I basically support the introduction of the VHIS, but I would offer you a suggestion. The tax deduction, which is capped at $8,000, is too low for people in middle age like me who are facing various health problems, high blood pressure, and the like. So I believe the major group of policy holders will be in the age group of 45 to 60 something. So you should set the cap at $10,000. Some better plans will cost you $20,000. The insurance company can come up with the products you need. Please do not cap it at $8,000. Raise the cap to $10,000. It's not very attractive to ask people to pay $10,000 and they get a tax deduction, actual tax deduction of $1,500. Secondly, you should allow people to take $5,000 from their MPF account, and then they can spend $15,000 on VHIS, and then you can get a tax deduction of $10,000. Then the coverage will be attractive. And I'm talking about taking out $5,000 from my own MPF account. If I earn $30,000 a month, I'm 45, I would take $5,000 from my MPF account. 5% are contributed, and 5% each is contributed by the employer and the employee. I will be the first one to join this, because I will be paying $5,000 of my own money from the MPF account. I don't have to wait until 65 to spend the money that I have in the MPF account. I will spend money to protect my health. For those in the 30s or under 30s, give them a cap of $10,000. It will be attractive to them. It will save them $1,500 in tax money. I think you have overestimated the popularity. But if you incorporate my suggestion of getting $5,000 from MPF, you easily get more than 1 million subscribers. Please note the suggestions, Secretary. Dr. Pierre Chan, second round, 3 minutes. Let's work out the sums. According to the government, you use the standard tax rate of 15%, and then you save $1,200. What kind of income would the taxpayers be earning in order to get the saving of $1,200? According to the CNSD, the median income is $16,800 a month, or $200,000 a year. You have the basic tax allowance, $13,200 for singletons, and Mr. Wong Ting Kwok has said. So you are in the tax band of 2% to 6%, and you will take a coverage of $8,000 in terms of premium. You have $400 to $600 deducted from your tax bill. So if you have to save $1,200, you have to earn $26,800, and they are not even paying the marginal tax rate of 17% for most employees. If the taxpayer takes out the insurance for himself, he will not be able to enjoy the tax deduction to the full extent. But of course, if you buy a plan for yourself, your spouse, your father and mother, and your children, well, how can the taxpayer do this while supporting all those family members, and buy and take out an insurance coverage, paying the tens of thousands of dollars in premium in order to save the amount of money that you have put in the paper? If you look at the table of the IRD's tax allowances and the CNSD's medium income for employees, so I believe that the tax deduction and the actual tax amount of tax saved will not be as good as you have suggested. So how optimistic are you when you say you expect 1 million people to subscribe to this? As Dr. Chan has said, the marginal tax band is from 2% to 17%. If your income is low, naturally you'll be paying at a lower rates. We have given some examples in the paper. They are examples. Individuals differ in terms of the income and the tax pay, as well as the age group one is in. It's very complicated. So we are just giving these as examples. May I remind members that this is not a paper on VHIS. This is about a legislative proposal to tie in with the introduction of VHIS in respect of tax deductions. I believe members should have another opportunity when the Bills Committee set up for the VHIS itself is formed. All right, we have another item on seasonal flu. So I believe that since so many members are interested, I would extend the meeting to 7:30.
好，咁啊，多謝啊副局長同佢團隊嚟啊。
I'd like to welcome the Undersecretary and his team. We have a big team of officials. Members have many questions, and I believe we are going to have more and more seats taken in the meeting room. So to save time, Undersecretary, let's spare the introduction. Members who would like to ask questions, hands up, please. I'm going to retire in 10 years' time. Not some of fellow members. I suppose members have read the paper. Mr. Wilson Orr and 5 other members would like to ask questions. 3 minutes for each member. Let's start. Mr. Wilson Orr, thank you. With regard to the 5 hospital projects under the 10-year hospital development plan, I support them. In particular, the one for Our Lady of Mary Lord Hospital. I joined this council, and then at the first motion I moved, it was on the healthcare in East Kowloon. It was carried. But this time, for the redevelopment of Our Lady of Mary Lord Hospital, there's no applause from Wong Tai Sin residents or Wong Tai Sin district councillors, because Wong Tai Sin residents would like to have A&E service. In this plan, they're going to have more beds. It's going to be phased in. The district councils said the additional number of 16 will not be good, and now they have responded by saying that there will be 40 more beds. In Wong Tai Sin, we have 425,000. In 2020, it will be 426. In the future, there will be an elderly population of more than 100,000. In the consultation at the district council, all the relevant parties wanted you to review the provision. They would like to have A&E service and also night outpatient clinic service. At present, residents of Wong Tai Sin will have to be sent to the United Christian Hospital or the Cromwell and QEH for emergency treatment. You are going to spend $40 million, and still the number of beds is so low, so please do more. Please also redevelop the Wong Tai Sin Hospital at the same time, which was completed in 1965. Undersecretary, you have heard the views of Wong Tai Sin district councillors and Wong Tai Sin residents. The DAB had talked about this, and we have had so many discussions with you, and it seems that our views have fallen on deaf ears. Undersecretary, thank you, Mr. Orr, for your questions. We have been paying attention to the aspirations of Wong Tai Sin district and the district council. We are going to develop the plan in all the 7 hospital clusters. And there will be some reshuffling for Kowloon Central and Kowloon West clusters to tie in with service needs. Sorry, I would like the Undersecretary to reconsider the offering of a 24-hour service of A&E department. Our Lady of Maryknoll Hospital is a community hospital. It is status in the cluster is a community hospital. When we have the new A&E hospital in Kai Tak, that hospital will offer A&E service to Wong Tai Sin.
So we do not plan A&E service for Our Lady of Maryknoll Hospital. I support the 10-year hospital development scheme, the 5 projects, and I hope other members will support that too. Now, I asked the administration about $30 billion out of $50 billion being gone. Now, I'd like to ask about hospital beds. Now, there are about 5,000 hospital beds, about 2,400 for the Kai Tak development. When the Kai Tak hospital is completed, the software and the patients will be at QEH will be relocated there, and then QEH will be redeveloped. Now, in the last 10-year scheme, the government talked about $200 billion, and now in the current 10-year scheme, there are 5 hospitals for redevelopment and expansion. We are talking about only less than 1,000 beds being added, and at QEH there will be a new hospital. There will be 3,000 to 4,000 beds more. Now, so in the new scheme, there will be 2,000 odd beds, so those will be lost at QEH, and now you shouldn't include them because they are not new ones. They just replace the ones at QEH. If you're talking about new beds, they should be new beds at Kai Tak and QEH. So on Our Lady of Maryknoll Hospital. Now, existing healthcare workers asked. The government said that it wouldn't build an A&E department there. Well, but will they provide 24-hour clinic? Now, actually, at that hospital, they previously provided that service. Maybe it's not A&E department, but there will be 24-hour clinic. That will already be helpful to the residents. Now, the staff are willing, but the government wouldn't provide the resources. And will there be a provisional new building at Our Lady of Maryknoll Hospital? Now, first on the number of beds. Now, when we introduced the 10-year scheme, we were referring to the number of beds at the Kai Tak hospital, and then in the second phase we include the new beds added at QEH. We haven't actually worked on the details on the redevelopment at QEH. We believe the arithmetic will work out. Some of the beds will be a relocation, and when phase 2 is completed, whether it's the new Kai Tak Hospital or at the existing QEH site, there will be beds added. Perhaps the Undersecretary can provide a table on the 24-hour service at Our Lady Hospital. Now, previously, when local residents felt unwell, they could knock on the door and ask whether they could receive treatment. Now, at hospital authority, all along, when we consider the general outpatient service, we do not plan to provide 24-hour outpatient service. Now, we are talking about chronic illnesses, diabetes, and hypertension, and also light illnesses like diarrhea or influenza. So these do not require a 24-hour service. Some members of the patient, of the public, they are concerned, they can't tell whether it's acute. Now they approach the A&E clinics. Now we can cater to that. We have the triage service at A&E departments. So we have 5 categories, and we allocate, assign the patients accordingly. On redevelopment, will you have a provisional building? It's relocation in situ. Now, the outpatient service will be provided locally. As for hospitalization service, now because of limited space, it cannot be provided in situ, so it will be other non-acute hospital beds in Kowloon Central, which will plug the gap. Helena Wong, the Democratic Party supports the 5 works projects, and other members will speak too. Now, I'd like first to talk about Cromwell Hospital. Now, all along, we hope that the government could liaise with different departments to deal so that there can be a passageway from the Yamate MTR station that connects directly to the new wing at Cromwell Hospital. Now, there's no progress so far. It is said that there is difficulty. We hope that the MTRCL could be talking to the HA on this. There are many local residents who wish that they don't have to walk first to the ground surface and then cross the road, because the population is aging in that area. I hope the government can do something in that regard. And paragraph 5 of the document says that for Cromwell Hospital, in future, we will relocate the Chinese medical service to there. Now, there will be 50 self-financing beds. Now, the government supports Chinese medicine. It might rebuild the Chukwan-O Chinese medicine hospital. Now, why is it that these beds have to be self-financing? And finance at Cromwell, they will have chemotherapy and oncological departments. Now, many people wish that there would be Chinese medicine treatment after chemotherapy. Now, if it's self-financing, it would be too expensive. Now, on the link between the hospital and the nearest MTR station, we know that right now the public have certain aspirations about accessibility. If the elderly or those who are not so mobile, if they are able to approach the hospital in an all-weather passageway, that would be desirable. We've been in contact with the MTRCL, but technically it's quite complex, and the cost might be very high, and the route might be rather twisting and turning, and or otherwise there may have to be new entrances. So we are still continuing with the discussion. As for Chinese medicine service, now Cromwell Hospital was one of the earliest hospitals which provide Chinese medicine service. It provides outpatient service, and at some wards there are joint consultation service involving Chinese medicine. So several years ago, when the hospital is contemplating redevelopment, they thought that since they are experienced in Chinese medicine, they can provide joint Chinese and Western collaboration in some wards. So that was incorporated in the expansion scheme. So at that time there was no formal plan yet to build a Chinese medicine hospital in Tseung Kwan O. And I think by the middle of this year we will be more clear about how that Chinese medicine hospital is going to be built and how it will be financed, and what role would Chinese medicine play in our healthcare system. So we will revisit the issue. So these 50 or so beds at Cromwell Hospital on how the joint consultation is going to be provided, we will revisit that. So the 50 beds or so, the government will pay for that. We haven't firmed up about the financing mode. For the Tseung Kwan O Chinese Medicine Hospital, we were talking about the possibility of government building the hardware, and then a private institution would run it. I'm concerned about the redevelopment of the Grantham Hospital. Now, how it's going to be positioned. Now, the Western Cluster, now by 2040 there will be 48% more elderly. So when you position Grantham Hospital as a hospital mainly treating cancer patients, you can imagine that there will be many elderly patients who would receive chemotherapy and cancer treatment, and but transport accessibility is poor for Grantham Hospital. So why is it that we haven't heard the district councils voicing requests for pedestrian footbridges or subways to link the hospital to public transport? Do you have plans to link the MTR station to the hospital?
Undersecretary, I thank the member for the questions. On the expansion on redevelopment of Grantham Hospital, the details can be found in the paper. Residents and the district council are concerned about the accessibility of the new hospital. They want to ensure that they can go there safely. We have conducted some preliminary study on how to improve the accessibility. We are waiting for some recommendations from the consultant on the improving and providing more passageways. In the future, after the expansion, Grantham Hospital is 2/3 the size of Queen Mary Hospital. If you don't improve the accessibility, it cannot be done in the future. You should reassure the residents there that accessibility will be taken good care of. As for the connectivity with neighboring areas, we would also ask the consultant to give us recommendations. Mr. Lee, but the 10-year hospital development plan has been much awaited by the public. They would like to see more beds, more healthcare workers, so as to shorten the long waiting time that they are experiencing. But I've noted that in answering members' questions, it seems that their wish will not be realized. They have been giving you more money. I believe Mr. C.Y. Leung gave you 100 billion, and now Mrs. Carrie Lam has given you more in the budget. We don't want to see crowded hospitals whenever we have an outbreak of flu, a seasonal flu. Well, it's not that you don't have the funding needed. We have to wait for more healthcare workers to be trained. But it's a question about your mindset. Take the case of Our Lady of Marino Hospital. You're going to double the size, and you are not even able to increase the number of beds by 100. It's just going to increase by a few dozens. Is this because of the positioning that you have decided? You answered Mr. Orr's question in saying that this is a certain hospital. But to the residents, they want to have around-the-clock A&E service. And let's have a review after some time. That would be more reasonable, given that we are going to allocate so much money to it. And you're not going to even offer nice service. This is not acceptable to the residents. Since you have been given the resources, you can increase the manpower gradually. Can you set a goal for this expanded hospitals that you are going to offer nice service? And then you can consider adding more beds later. Well, it's just not possible that you are going to increase the number of beds by a few dozen, but the size will be doubled. The planning for Our Lady of Marino Hospital will involve using how we use the space. Some old hospitals are outdated in terms of the design. The per capita space for each patient is so low that it will not be it will not live up to modern day separations for infection control and comfort of patient. The space per bed will go up by 60 to 70% in the future. We have a long waiting time. I don't like fast food, but if I don't have food and I have a long queue to join, I would like to get more first. How can we explain things to the residents if the additional number of beds is just 40 or so? If we can increase the number of beds for clinical services, we can add 40 under the plan, and if we do not affect the parameters for usable space, we would consider making further modifications, but that would have to be done under the parameters of the total GFA and the services needed. For Kowloon Central, there will be a new hospital in Kai-Tak with all these facilities needed by the residents. There will be more and more. There will be a lot more A&E beds in the future, and then they will also be able to offer around-the-clock service. Well, that's why residents there are concerned, because Kai-Tak Hospital will have to serve many districts, and now they see this opportunity in the redevelopment of Our Lady of Mary-Law Hospital. So why do you want to stop this by saying that the hospital is positioned as a certain type of hospital? Can you tell us the difference? If we have A&E department, then they will be servicing the very acute patients and category 1, 2, 3, 4, 5 patients. The service will be provided by very experienced doctors. In terms of healthcare workers and equipment, A&E service is very different. For a community hospital, it's cater for patients with chronic diseases. Half of them are patients requiring the regular care, chronic care, and another half of the patient population belongs to those with occasional episodes of sickness. If we want to deal with acute cases, we should not do this by offering around-the-clock clinic service. In the Kowloon Central cluster, there will be 57% of A&E beds in the future, which will be sufficient to meet the demand. I know Ms. Dalili has proposed a motion, but now let's ask the next members to speak first. Mr. Wu Chi-wai, on the question of providing A&E and other services, we have been told that the hospital, Our Lady of Mary-Law Hospital, is a community hospital. But as the district council has commented, there's the problem with aging population, and elderly patients mainly suffer from bone fracture or a stroke, and there are hospitals offering some sort of a triad service, such as North Lantau. Acute patients will be transferred to other acute hospitals. So I think Our Lady of Mary-Law Hospital should be positioned in the light of the aging population, and they should offer targeted services, such as bone fracture cases and stroke cases. So that is a sort of a triad hospital service. You may not be able to solve the problems if you were to consider offering A&E service, but what about offering transfer services? Why are there so few beds in the redeveloped hospital? It's because you provide 9 square meters per bed, which is spacious. But I have learned from the press that for the Cromwell Hospital plan, the space for each bed is 7.5 square meters. So it can be 7.5 meters. Why don't you ask Cromwell Hospital to offer 9 square meters? So can we adopt this standard 7.5 square meters for Our Lady of Maryknoll hospitals, so that we can have more beds. Because with more beds, you have to deploy more manpower. If the benchmark is set at 7.5 square meters, then you have more beds, you can deploy more manpower, and that will enable you to offer better services. Can that be done, Undersecretary? Thank you, Mr. Wu, for your question. On the question of triage service, a member has referred to the relationship between North Lantau Hospital and Princess Margaret Hospital. But this is not a different case, because we're talking about a long distance between North Lantau to Kwai Ching. So a more stable short-term arrangement may be more appropriate. But when we're talking about the urban districts, the new hospital in Kai Tak will be close to Wong Tai Sin, and traffic will be much better with a more advanced road network. So it cannot be compared with the relationship between North Lantau Hospital and Princess Margaret Hospital. As for the space for beds, we would like to comply with modern-day nursing and infection control standards. Actually, the bigger the space, the better, especially for those patients in rehabilitation. We need to provide this space. So we should not reduce the space entitlement. But we will reconsider your proposal, because at the end of the day, we would like to see more beds. The overall principle is to look at the space allocation to see what more can be done. Dr. Elizabeth Kwok, we don't have sufficient hospital, and we don't have sufficient beds. When there's a peak flu season, the hospitals are so overcrowded. Now we have reserved funds for these hospital development plans, and the lead time is very long. So members would certainly like the government to seize the redevelopment opportunity to do the optimum job to meet the rising demand because of the aging population. The community needs around A&E service around the clock, and we need more beds. If you redevelop a hospital and you cannot at the same time provide more beds to meet the needs, it's just a refurbishment project. People would be very disappointed if that's what you want to do. You have talked about the established rules or the GFA in the established plan. Who make those rules? We are now in such a critical condition. Are those rules not amenable to changes?
Now, unless you change your mode of thinking, we can't resolve our future problems. So the public feels that the government is very bureaucratic and inflexible. You don't really cater to people's needs. We members do not understand. You are going to redevelop the hospital, and yet still you don't jump out of the current framework. So can't we build more hospital? Can't we have more hospital beds? Can we do more? We thank Ms. Kwok for her question. Now, looking at the Kowloon Central Cluster, after completion of the first 10-year plan, the net increase in beds would be 1,000. for acute and recuperation beds. Right now there are 4,800, so there will be a 20+% increase. When we calculate the expected increase in patients, now we take into account the new developed areas and the change in population distribution. So we think the 20% increase should be able to satisfy the future demand. So just to reiterate, on the basis of plot ratio and usable floor area, whether we can have more beds, we will consider that. Now, the plot ratio and the floor area ratios, can you break out of the current mode? We will go back and reconsider. I think the government is rather incapable. Now, the hospital authority is rather incapable. It is going to fork out $300 billion now, but you won't budge when the members request more beds. Now, I'd like to ask the Undersecretary, when we set up the standard years ago, 10 years ago, do you know how many beds per 1,000 population? It was 5.5. It was 20 years ago. Now it's now been over 20 years. We are still lagging far behind. And now our elderly are 70% of population, 2026, 25%, 31% by 2036. So when your next two plans are completed, it will be 2038. And you are saying that it will be enough. You will never catch up. So the administration and the HA still refuse to increase the number of beds. I don't understand why. Now in winter, in the flu season, for internal medicine, the hospital bed utilization rate is well over 130%. Now, what's the current shortage of internal department beds, internal care department beds in territory as a whole? And when will the new cycle begin? In New Territories West, there is no new bed under the 10-year redevelopment plan or development plan. Concerning the 10-year plan, the number of beds anticipated, we said in the document that there would be almost 5,000. Now, I don't want to repeat. 5.5%, that's the standard 20-odd years ago. It won't be enough after 20 years of hospital development. Let him answer, please. Our plan takes time, so whether it's the preparatory work or the detailed design, those take time. So we are already proceeding as quickly as possible on phase 1, the first 10 years. So we hope that members will support our proposals. Then we can launch what we plan. Now, on internal service, shortage of hospital beds, and the second cycle, can that start earlier? These two are specific questions. Can you supply information later? What's the shortage? We will go back and prepare some information. Now, Dr. KWOK Ka-ki wants to know what's the shortage in internal care beds. Now, on the relationship between phase 1 and phase 2, of course we want things to happen quickly, but we are working hard on phase 1 and we want to plan ahead for phase 2. In the government report, they've already named some hospitals. So we want to start quickly. Chen Chi-chun. All the various political parties support the 5 development proposed developments, but we want you to do more, to provide more beds, to have longer hours of service. The administration is anxious. Mrs. Carrie Lam said at the beginning of the month, and she named Our Lady of Marino Hospital, Cromwell Hospital, etc. And she said that the councils are very worried. Now, we all support these items. The various political parties put forward constructive ideas. Now, what is the speed you have in mind? Now, the candidates accuse the pandemocrats of filibustering, and the CE voiced her views as well. Now, actually, you are only proposing these items today, so how can we be in the way, as some people claim? Now, you hope that this can be passed before the summer recess. Will you ask the FSTB to put these items earlier in the list? Now, if you put these items after the controversial items, then again there will be complaints. Now, let's not make these accusations that we filibuster to stand in the way of hospital development. Now, $200 billion have been set aside for development. Now, how many more proposals do you have? Let's have them. Do you have an overall plan for us? Now, the healthcare services panel wouldn't filibuster, on this because this is just going through this panel before it proceeds to the next stage. Mr. Chen Chi-chun asks, how quickly do you want this item to go through? And then they can plan on their strategy. Now, on the 5 proposals, now there are 3 of them on the advanced works. The other 2 are preparatory works, and if passed, all 5 can start in 3rd quarter or 4th quarter of 2018. On the first 3, the Kwong Wah, the Queen Mary, and the Kai Tak Acute Hospital, we expect that they will be completed by 2040. Now, Food and Health Bureau will always try to be helpful. How urgent do you is your plan for these items? What priority will you give them? I hope the administration could provide some items of information. Now, people were saying that there are not enough beds. Now, per 1,000 population, how many beds, hospital beds in Hong Kong are there, and how many will there be, and how do they compare with other jurisdictions? Please provide those data next time. Starry Lee and Oh Chong Sing mentioned this point. Now, on Our Lady of Marino Hospital, there is no A&E department. Now, but Oh Chong Sing also talked about 24-hour outpatient service. Now, look at the AED patients. Many of them are really not urgent cases, but they cannot see a doctor during the night, not even at private doctors' clinics. So they go to AED, and there is a long queue, and it's a very high cost at AED. So this is the wrong use of money. So we just want you to have 24-hour outpatient clinics to deal with ordinary cases, not urgent cases. This would be a better use of resources. Why is it that you do not agree? And the secretary said just now, the outpatient clinics are dealing mostly with chronic patients. They come every 3 months for medicine. Now, you can provide that service at the health care centers. And and you don't have enough outpatient service, and so people go to AED. Now, $200 billion, $300 billion for the hospital authority to build hospitals. Now, primary health care is inadequate in Hong Kong. So how much resources do we have to inject? Now we are building hospitals, we are adding hospital beds. Now people don't get the service, so they go to AED, and then so they take up the beds in the hospitals.
So the beds will always be insufficient. So you're not going to deal with the real problems. We want you to introduce outpatient clinics, and you say no. Then I don't think we would ever get enough hospital services. What's the reason for rejecting the idea of 24-hour outpatient clinic at the hospital? Well, they have night clinic service. There are different facilities providing the night outpatient clinic, evening outpatient clinic. Well, it stops at 10 p.m. After the redevelopment of the hospital, and when we have the Kai Tak Hospital, well, please don't talk about Kai Tak. We are talking about Our Lady of Marino Hospital. We can extend the service hour to 12, and we will monitor the service. What about Our Lady of Marino Hospital? Are you going to provide 24-hour outpatient clinic? Please don't repeat the answer. Yes or no? If it's yes, we were going to follow up. If it's no, then we will do something else. Well, it will be extended. The service hour will be extended to 12 o'clock. 2 more members want to speak, and we have the motion. We have to deal with the motion moved by Mr. Lee. So please sit tight, and we would have Mr. Wilson Orr, 3 minutes. Miss Dr. Pierre Chan, can I return to the question I raised in the last round? For the first 10-year plan, there will be 5,000 beds. No need to tell me. For the new plan in the budget, Princess Margaret Hospital, Tuen Hospital, expansion of North Lantau, it's expected that 3,000 to 4,000 additional beds will be added to the system. So please tell us how the number is arrived at. For Kwong Wah Hospital, there are 360,000 patients served by the specialist outpatient clinic. After the redevelopment, the number will go up to 600,000. Ultimately, Kwong Wah Hospital will provide hospitalization and specialist treatment services. The residents have a big demand for the primary care. So how can the redeveloped Kwong Wah Hospital share the workload of QEH? How are you going to deploy the necessary manpower to meet the demand in the district? Thank you, Dr. Chen. I cannot give you the data, the figures now. I can give you an answer after the meeting. Paragraph 141 of the budget speech says it's expected that 3,000 to 4,000 more beds can be provided. Of course, you gave him the letter. All right, let's have the answer.
大家咪不有咪算咯。咁啊，但係我就好珍惜呢個事務委員會，就算個。
Although this is just a formality, as you said, Chairman, we have the head of service. It's a good opportunity to ask them how the plan for the redevelopment of Kwong Wah will be implemented, and also the how the resources can be provided. If we take a look at the manpower and the hardware, the figure is about the service capacity when the hardware is ready. There's another mechanism, and there's another timetable actually for the manpower and resources to so as to utilize the capacity, service capacity to the fullest extent. Now we have everyone seated. Let's deal with the motion moved by Mr. Lee. Now, Ms. Lee, please read out your motion. Thank you, Chairman. It's set out in the paper that I have submitted. Members are concerned about the redevelopment plan for Our Lady Our Lady of Mary Law Hospital, we want to reflect the views in the district. First, this panel asks the government to expedite the redevelopment of the hospital, and also to increase the service by having A&E or 24-hour outpatient acute service. Second, increasing the number of beds, expand the service scope and the service capacity. I believe that the Bureau has agreed to consider this one, but they are not willing to consider the first one. Perhaps in the initial stage, you can offer 24-hour service. And then if people really go to the new hospital in Kai Tak, then you can cut the service. All right. I think we have heard the motion. If members do not wish to move amendments to the motion, I wonder if there's any objection. If not, then I take it that it's agreed by all. So it's carried. This motion moved by Ms. Starry Lee is carried. I'm not a panel member. The more I listen, the more angry I become. It seems that the Undersecretary keeps repeating prepared answers. Actually, in the District Council, there's a consensus among the different parties, and now this motion is also carried. Why, Undersecretary, why are you not willing to change the mindset? What is the additional recurrent funding if you offer 24-hour acute outpatient clinic? What's the additional recurrent expenditure that you need to expand? Apart from a recurrent expenditure, what other factors do you have to consider? Why don't you start it first and carry out a review? And also for the Kai Tak development and the Kai Tak new hospital, you cannot expect that everything would go smoothly. You're not saying that there will be seamless transition. And you're going to redevelop Wong Tai Sin. Wong Tai Sin Hospital was built in 1965. After you completed the plan for Our Lady of Mary Law Hospital, you should consider. Are you talking about 24-hour outpatient clinic or acute service? If that's if you're asking for acute service, you are asking for an A&E department. Well, I'm talking about outpatient service. Well, different hospitals and clusters will need to work in synergy. That's always one of the important factors that the HA considered. Every hospital has to play a different role. Some are A&E hospitals, some are community or district hospitals. And in the redevelopment plan, this is also one of the factors that we have taken into account. As for extending the service hours of evening outpatient clinics, I haven't said that this is a question of resources. We are only talking about the capacity of the cluster, which we think is sufficient. As for 24-hour outpatient clinic or A&E service, I cannot give you the relevant figures now, but we can do this later. After the redevelopment of Our Lady of Mary Law Hospital, the evening clinic service hour will be extended to 12 midnight. It's difficult to anticipate whether the service capacity will be sufficient or not. We extend it to 12 first. And if there's still some service needs unmet, we can rely on the new Kai Tak Hospital. And Wong Tai Sin Hospital is an old hospital. and it's close to Our Lady of Mary Knock Hospital. So in the second 10-year hospital development plan, we would certainly consider whether we should provide a redevelopment plan for Wong Tai Sin Hospital so as to achieve synergy. I don't accept the replies if the Undersecretary doesn't give us strong justification for the government's position. We are going to put up some resistance at the FC. I think Mr. O.R. has asked you about the resources required if the outpatient clinic is to be provided around the clock. And also at the Wong Tai Sin Hospital, there is residential care homes for the elderly. There, you have to relocate the RCHE first. So this paper is introduced for the purpose of consulting panel members. There are 5 projects, but there's no one here representing Hong Kong Islands. No question has been raised for the QMH redevelopment. All right. Ms. Dory Lee has moved this motion. Please respond to the motion and also other questions and requests for figures. I was actually expecting a second round. Okay, you can put your question again. So sorry. Thank you for your indulgence. I hope the Undersecretary can reconsider the case. The reason that you are not going to provide 24-hour outpatient clinic service at the new hospital, because you think that there is sufficient capacity. Ask anyone, and I don't think you will get the same answer. It's not a question of resources. It's just that you don't want to do it because you've considered the present, the future capacity will be sufficient. I would like you to try it out first with 24-hour service, and then if the service need is not big or that the Kai Tak new hospital can take care of the matter, then you can reduce it. Well, other district councils have offered similar views, but not as unanimous as Wong Tai Sin. So can we do this in the first instance for Wong Tai Sin? All right, you have heard members. Undersecretary, members, please stay with us. Let's have another team of officials. Some of them may have to change seats. We have the next item coming up. Is response measures for seasonal influenza. I would allow the members to raise questions after the officials have spoken. In principle, we can go all the way until 7:30 p.m.
大家都要交代。我哋歡迎有關官員入席嘅講呢個流感嘅。
Oh, the subject is seasonal influenza. Dr. Wong, take a seat, please. It's item 5. Secretary, over to you for a briefing. Undersecretary, the subject is response measure for seasonal influenza over the years. We are talking about the winter surge or sometimes a summer surge as well.
So we attend to them very seriously. So we draw on experience to improve our measures so that the public gets proper treatment. We provided a lot of information in the paper. I will not go into details. Now, the Department of Health and the HA have regular measures. We will use the one-off $500 million funding to introduce fresh measures so that more helpful services will be provided. Now, the winter surge this year has caused a lot of concern, and so in January this year, we have increased increased the resources for vaccinations by 44,000. Now, Chen Yin and KWOK Ka-ki, 5 minutes each. Now, concerning the winter surge, now we've been discussing this for the third or fourth time since I've been here. Now, on publicity and education, now the doctors and the administration propose that they should wear face masks and be vaccinated for seasonal flu. This is your what you're trying to educate the public about, and some personages have spoken on this. Now, I'll give you some figures. Now, a well-known person has issued a blog on his website, and there have been 10,000 likes and over 1,000 messages, and the Center of Health Protection responded, 22 likes and 0 messages. And this is a very big difference. So the public is very concerned about vaccinations. Now, now there are groups around the world against vaccines, and now I hope the government can provide an accurate response. I cannot be the authority. Now, concerning the lack of acceptance of the public for vaccines, there are many reasons. Of course, we try to understand the people's views. Now, previously there were studies by us on people's concern about vaccines, but we need to do more analysis and study on that to see why different groups of the public have difficulty accepting vaccines. So we will do more data gathering and analysis, and Dr. Wong can supplement on public education. Now, publicity and education is important, and seasonal flu vaccination is a very important means of prevention. Now, some celebrities said certain things about seasonal flu, and we issued some clarifications, and we worked through some new media. At the same time, there were medical experts, and Mr. Chen, Dr. Chen helped, and there were quick responses within the healthcare community, and I understand it was very helpful and well received. Now for vaccinations, the number has been increasing this year. The vaccination schemes and vaccine schemes now has been quite successful so far, and we are confident that in the future. Now I'm talking about publicity. The government should be proactive. You should have new modes of publicity. For instance, in 2016, the Education Bureau got Lai Ming to speak to the young people and so on. So the celebrities can gather many likes on the internet. The experts are not trusted. The officials only garnered 20 likes. So the government needs to do more on publicity. We thank you for your views. The Department of Health will consider getting the help of celebrities, but we need to strike a balance as well. Dr. KWOK Ka-ki, first, the $500 million. Now, which groups of the public will benefit from that $500 million? Now, otherwise it's only piecemeal. Now, every year when the flu arrives, it's disastrous. And when the parents want their children to be vaccinated, they need to make reservations early, and it's very difficult to get. I said many years ago that we need to go to the schools to vaccinate the children. Macau is already doing that, and they have less resources than we have. And government here is adopting half measures. It's half-hearted. Before long, it will be the next cycle. Will the government take the steps needed? The current measures are totally inadequate. And we know that at every hospital, when it's flu season, they are bursting at the seams. And it's not just the flu. There's a seasonal peak in winter. And the government is building new hospitals or introducing new beds, but too slowly, especially for the elderly. Now, you should have some special clinics in peak seasons within the community, and it should provide the special flu treatments needed. And will you have schemes for doctors visiting the center, the residential homes for the elderly, so that the elderly don't have to go to the hospitals to get treatment? And how much are you spending on Tamiflu every year? Concerning the $500 million, mainly is to increase our manpower to provide service. So I like to ask, how much of it is directly spent on the patients? How many more vaccinations for children and the elderly? How many specifically? Now, that's a one-off funding, the $500 million. It's mainly to pay for staff in different categories of healthcare, so that where inpatient needs are strong, there would be better care. So it's indirectly or directly spent on patients. Now, as for vaccinations at schools, of course, we see some benefits, and in the coming winter flu season, we will consider increasing the coverage of vaccinations, especially vaccinations at schools. Now, as for other support measures to reduce inpatient needs, for instance, outreach to elderly centers or elderly homes, we are already doing that, but maybe we can increase the frequency of service. Tamiflu, Dr. Wong? On Tamiflu, it's a contingency plan on flu epidemic, and we have stocks of Tamiflu, but there is a period used by date for some of the stocks, and so we have to replenish the stocks. We will provide the data. So you increase the frequency to the elderly homes, and special clinics, those have not been answered. And instead of throwing away the outdated Tamiflu, why don't you provide them earlier to the community? And by peak season, Tamiflu is not available in the community. You cannot buy it in stores. The government knows that. So you should delegate the availability to the community. I know you throw away dozens of thousands of tablets of Tamiflu every year.
Undersecretary, how many Tamiflu medicines thrown away annually? I don't have the figure. Dr. Kwok proposed setting up fever clinics, sending outreach teams to RCHEs or elderly homes. Do you have any comment? Well, we have outreach teams to RCHEs. During the winter surge, we have been sending doctors and nurses to RCHEs, and also for stationing more people at the A&E department, so as to provide service faster to these people. And in accordance with manpower deployment, they can change the frequency, increase the frequency of such visits. I have a question for the experts. Dr. KWOK Ka-ki says you have thrown away a lot of Tamiflu. And he said that you can give Tamiflu to those who are susceptible of having an infection or a flu, if I think I have flu, can I ask Dr. KWOK to give me Tamiflu, or can I get it from a community pharmacy? Can this be done? Or you're holding on to a lot of Tamiflu and you won't prescribe it until absolutely necessary. That's why you have thrown away some stocks at some stage. It's been suggested that when we have a serious seasonal flu surge, and when we cannot handle the number of patients requiring hospitalization, we are talking about preventive prescription of Tamiflu. There was some discussion. Experts have some reservation about pre-exposure prescription. Maybe we can do it earlier for post-infection prescription. At present, we only do this when we have a very serious surge. Maybe we can do more for post-infection. Well, you need to do more public education. If I have a cold and I don't know if it's a flu, I will take a Tamiflu. It will be drug abuse. So perhaps you should educate the public about the proper course of action. Second round, Dr. Pia Chan. I can find the figure of the amount of Tamiflu thrown away after I've gone back to my office. I believe annually we are throwing away 200,000 to 300,000 doses of vaccination. From 2011 to 2014, we are talking about 1/6 of doses thrown away without use. Apart from Professor Yuen Kwok-yung, Dr. Ho Pak Leung, the mycological expert, has also proposed sending out vaccination teams to primary schools to offer service to primary students. And the Center for Health Protection has talked about the need to look into the necessary manpower. Some doctors volunteer to do this, but the problem lies with the transportation of doses. The DOH has a very professional, very good refrigerator to store the doses. And schools are concerned that parents may be worried about the side effect. The Undersecretary has indicated a willingness to reconsider. So what are you going to reconsider? Please be precise. Have you estimated the cost? All right, I can offer the funding if I'm asked, and also how many more people, how many more people do you need to hire, and also what's the current state of manpower? Are there problems that we need to help you to handle before we can do that? At present, vaccination service in the school are arranged by the schools with private doctors. And Dr. Chen has referred to some of the problems for those who have not yet been covered by this arrangement. We have more than 1,000 kindergartens, nursery centers, and more than 500 primary schools. If we cover all of them, and we may not be able to cope because of sheer number. But initially, we may wish to do more for primary schools, and that is the outreach service to primary schools can be expanded. As regards side effects, if we ask the schools to tender for such service from private doctors, they think it's too complicated. So if we do it, that would streamline the procedure. We need to have vehicles with the refrigerating equipment, and also the syringes will have to be disposed of after the vaccination is done as medical waste. And if we were to do it, we can also handle the medical waste, so that schools would be more ready to accept the services. It seems very difficult. Of course, they are talking about a large number of clients. There are existing programs for primary schools, different vaccinations, not through German measles and so on and so forth. The vaccination rate for primary students is just 10 to 15%. Well, if it's doubled, then you have sufficient doses, because you have thrown away tens of thousands of doses annually. We need actual figures before we can help you. How many people you need, how many schools will be covered. Don't just talk about enhancement or improvement in abstract. We can't help you if you do that. Please calculate the sums and the figures. Dr. KWOK Ka-ki, maybe let's give them some time to respond to the questions on how to enhance school service. I think you know better than I do. In many places, their health authority and their education authority will work together in vaccination. They will get the consent form signed well in advance. And if the government doesn't have enough manpower, it's not difficult to get doctors or part-time nurses to help you if you are going to do it. Can you tell us more about your thinking on service improvement? And since we have been wasting tens of thousands of doses, can the doses be made available to the community? For example, by making them available to private doctors. And it seems that the government hasn't got any new policy to encourage people to get the vaccination, apart from the targeted population that you have been talking about. It's just 10%. Well, it's really not a very acceptable level compared with neighboring areas on how we can improve vaccination service for schools. I've already mentioned some of the proposed measures. For example, how we can do away with the tendering process. We can ask someone to do the vaccination, such as doctors. Second, on transportation of the doses. If we can get a suitable contractor to do this, that is for the provision of transport vehicles with refrigerators. There's a limit here. We don't have many such vehicles with the necessary refrigerator. The service capacity in Hong Kong is limited to an extent, so it's a bottleneck here. And also for the doses, after the doses are given, we will have to get a contractor to deal with the medical waste. If we can make the arrangements, we believe we can offer a better choice. Let's set some goals through the measures that you have mentioned. To what extent can you improve the vaccination rate? But we're still considering the arrangements. I think I can provide an answer together with the answers for other questions after the meeting. What's your projection? Well, there are two markets that we need to pay attention to. We have the government vaccination program, and secondly, we have a subsidy schemes involving private medical practitioners. And then the third part of the matter is the service offered through negotiation between private doctors and the clients. We don't know whether the people are not coming forward because of the lack of sufficient subsidy, or is it due to some other questions. But we cannot cut it too fine. We have to procure sufficient doses so as to prevent a situation whereby we don't have sufficient for the government vaccination program. In the middle of a flu season, and if we know that we don't have sufficient vaccination doses, we can ask the manufacturer to replenish the stock. And in this year's case, we managed to get 20 to 30,000 more doses. Dr. Pierre Chan, through the HA, well, the government buys service from private hospitals to cope with the surge. How much money was spent last time on buying back service, and how many patients used the service? So public funds expended, that's the first question. Second, in this document, you don't mention the procurement of a hospital's bed service again. According to some private hospitals and private medical practitioners, when you wanted to buy from them, they didn't have enough to go around among themselves. So how are you going to deal with this problem? Do you have the information? I'll ask Dr. Ko from HA to respond. In the last flu surge, we transferred some patients to St. Teresa and the Adventist Hospital in Tsuen Wan. 21 patients were transferred in that exercise. After the surge ended, we only have the full figures of the expenditure. After the end of the surge period, we are still in that surge period. All right, they will provide the answers in writing. And you also mentioned, Dr. Chen says it's not mentioned in the paper, but it's still ongoing. But we can only refer suitable patients. I just want to know that you are spending the money in the right way. And I would like to know whether it would cost us tens of thousands of dollars in referring a patient to a private hospital. Is it a good way to spend public funds.
咁啊，借一次睇下先用咗幾多錢咁啦，陳議員。
Perhaps you can use today as a cut-off date and let Dr. Chen know the expenses involved. So we have concluded the third round. So the issue comes back every year. We hope that the problem would be resolved next time. The Undersecretary, please provide written information. So just to inform members, even though there are not many of you here, no AOB for now. On the 26th of March in the morning, there will be a public hearing. And next meeting, 24th of April, 4:30, 3 topics. Thank you for attending.